Stanford University.
Welcome, and what I'll try to do in the next maybe 20 minutes to half an hour is talk about a new treatment option for patients who are at high risk for the traditional treatment for what's called aortic stenosis, and the traditional treatment being open heart surgery. And this new option, the fancy term is transcatheter aortic valve replacement, and what that means is replacing the valve by using a catheter or a tube, and I'll describe how that's done. If we could go to the first slide here. This is just to introduce you or reintroduce you to the anatomy of the heart. You'll see this is looking at the heart from the outside, and there are blood vessels that course around the heart called coronary arteries. And those are the vessels that, when they get blocked up with atherosclerosis or plaque buildup, cholesterol plaque, can end up causing heart attacks. But we're not going to be talking about that problem, although it is a major issue in our current healthcare environment. What we will talk about are the valves in the heart, and in particular the aortic valve. And if we go to the next slide, you'll see the heart's now cut in cross-section, essentially. And there are 4 valves that are shown there in the heart. The one that we'll be talking about is the aortic valve, and that is the valve that sits between the left ventricle, the main pumping chamber of the heart, and the aorta, which is the main blood vessel that gives off branches to our brains and the rest of the organs in our body and limbs. And this valve is made in such a fashion that it allows blood to leave the heart, and then it closes and prevents blood from coming back into the heart. And when it becomes narrowed, which can happen with time as we get older, and certain conditions can contribute to that, the valve doesn't open as effectively, and blood can't leave the heart as effectively, and puts the heart under extra strain, and people can develop symptoms due to that. And that phenomenon is called aortic stenosis. Stenosis means narrowing. Let's go to the next slide. This shows again a picture of the heart in cross-section, as well as looking down at the aortic valve. And the aortic valve normally has 3 leaflets that open and then close. And you see how the blood should be getting pumped out into the aorta. And the next slide. So what I'd like to talk about is this entity, aortic stenosis, and the most common reason that people develop narrowing of their aortic valve is because of calcium and degeneration over time as we age. It used to be, and it continues to be in third world countries, that rheumatic heart disease was the most common cause for aortic stenosis. But now in the developed countries around the world, this calcific degeneration that occurs as we get older is the most common cause. And there's a term, aortic sclerosis, which, if we press the next slide again, it's the non-obstructive form. When the valve starts getting early calcification, it's still able to open well, but it appears sclerotic or partially built up with calcium. And then with time, that can turn into obstructive valve disease, which is then aortic stenosis. And the next slide. The etiology or the pathogenesis, the reason why this happens again, is not totally clear, but we think that the lining of the valve, what's called the endothelium, can get damaged. Inflammation can occur there, and lipid and calcium gets deposited. And in fact, it's similar to the issue that happens with coronary disease. And the risk factors that lead to coronary disease are similar to the ones that lead to the aortic stenosis. As we get older, our blood pressure, male sex, high cholesterol, and tobacco use all can increase the chance of aortic stenosis. once moderate aortic stenosis develops, then we can expect that it'll progress at about 0.1 square centimeter per year shrinking of the valve with time. The main way we diagnose it is by, first of all, taking a history and talking to our patients, and then also examining them and listening to their heart. And we hear an extra sound that is what we call a murmur, and that's a reflection of the turbulent blood flow across the narrowed valve. When we hear that, and when we elicit symptoms from patients that are suggestive of aortic stenosis, things like shortness of breath, sometimes chest discomfort, fainting, swelling in the legs, all of these things, they can be caused by a number of things, but aortic stenosis can cause these symptoms as well. Then, and we hear a typical murmur, then we will order an echocardiogram or ultrasound of the heart. And the ultrasound criteria for diagnosing aortic stenosis are shown here. And essentially, the valve should be 3 or so centimeters squared in area, but as this calcium deposits build up, it gets narrower and narrower. And when it becomes less than 1 square centimeter, that's when we classify it as severe aortic stenosis. So if we can talk about aortic stenosis in the elderly, as our population ages and people are living longer and longer, we are faced with patients who are developing this syndrome at increasing frequency. 3% of those over 75 have moderate to severe AS, and as we get to those over 85, 5 to 7% have severe aortic stenosis. So this means roughly 250,000 people. So it's a fairly important thing that we need to deal with. And what we have found is that more than a third of all patients, not just the elderly, but of all patients with severe aortic stenosis, are not referred for valve surgery because of a variety of reasons. This is a slide that shows that this issue is even more of a deal or prevalent in the elderly. These are 277 patients who were over 80 years old, all of whom had severe aortic stenosis. And you see that more than 2/3, 197 of them, did not undergo surgery for one reason or the other. And surgery, once a patient develops symptoms and has severe aortic stenosis, surgery has been the gold standard way of fixing it. We don't have any good medicines, unfortunately, to fix it, and we'll talk about that in a minute. And you see that those patients who didn't undergo surgery had a much worse survival. Now, this isn't a randomized study or anything, so these patients were probably sicker and had other reasons why they didn't go for it, but it just highlights the issue that we're faced with. Let's go to the next one. And one of the reasons why patients aren't being referred for the traditional treatment is because of the high risk in elderly patients. So shown here is data from the Society of Thoracic Surgery database, and what's circled is the operative mortality, or the 30-day chance of dying after an aortic valve replacement. And if you are between 80 and 89 years old, in this database, 9.2% of those patients didn't survive 30 days. And if you were between 90 and 100, it went up to 13.3%. So it's quite a significant number of patients and quite a high risk. And so that's one of the reasons why surgery is often deferred in people that age. Let's go to the next one. So what else can we offer? Well, medical therapy, we've known since the 1960s when this chart was first published that people live for a long time with this aortic stenosis as it gradually gets worse, and they often don't have any symptoms. But as soon as patients develop symptoms, you see in the top right there, the onset of symptoms, then the survival dramatically decreases. And the key thing is identifying patients who have symptoms when they develop, because that's a sign that things have gotten severe and something needs to be done. And if we just treat with medicines, the average survival rate is 2 to 3 years, so it's not very good. Let's go to the next. And those are, again, from the 1960s. You might say, well, maybe medicines have gotten better. Well, this is data from the 1990s to early 2000, and it shows the same thing, that 453 out of 740 patients who had severe aortic stenosis and were treated medically, meaning they didn't get surgery, there was almost a 40% one-year chance of dying. So it's a very grave situation. So what else can we do then besides medication? Well, there's something that's called balloon aortic valvuloplasty. And what that means is using a balloon to try to plasty or break open the aortic valve. And the way there's two different methods of approaching the aortic valve that are shown here. The most common way is by inserting a catheter in the artery in the groin and threading that catheter up around the aorta and going backwards, so-called retrograde, into the aorta or aortic valve and into the left ventricle, and then inflating a balloon and opening up the valve. And this was first described in the 1980s. And unfortunately, though, the initial series had very high complication rates, up to 25%. Although recently improvements have been made, and so there has been some revival in this technique. And some of the improvements are sort of technical, but essentially one way of making it safer is by, when we used to inflate the balloon, because the heart's still beating, it would just push the balloon out, and you couldn't get an effective dilatation of that valve. And also you had to do more inflations, and with each inflation you could increase the risk of a complication. Now what we do is we use a temporary pacemaker, a little wire that we have in the heart, and we temporarily pace the heart at a very rapid rate so that it can't beat effectively. And it's just for 10 or 15 seconds, so patients don't even notice it. But what it allows us to do is quickly inflate the balloon and deflate it, and it won't get jettisoned out. And that helps us improve our dilatation. We've also gained experience in dealing with the hole, or the arteriotomy in the groin, so that we're able to more safely manage it so people don't bleed as commonly. And this is a series from Los Angeles of about 80 patients who had this procedure. And if you go to the next one, you'll see that the gradient, or the pressure buildup across the valve, is something that we measure, and it allows us to determine how tight the valve is narrowed. And before the procedure, it was 51 millimeters of mercury, and afterwards it decreased to 23, so about cut in half, meaning that there wasn't as great a pressure buildup because the valve was opening more, and the area almost doubled from 0.49 to 0.9 centimeters squared. And if you go to the next one, you'll see that the complication rate was lower too than prior reports. Now, there's still a 6% chance of dying in the hospital in these patients, but these procedure is usually reserved for people who have, a 20 or 30% chance of dying that are quite ill. So you have to think of this in relatives terms. This isn't for people who are walking around perfectly healthy. It's usually for people who are quite ill that we do this procedure. And we've recently reported our results in a smaller number of patients using even smaller device or balloon that allows us to, we think, make it even safer as far as the chance of bleeding or complications. And this just shows that there was also a significant improvement in the gradient and the valve area. And then the complication, or this is first the symptoms. Basically, we classify how symptomatic people are, where class 4 is really bad and class 1 is not bad at all. And you see that class 4 was in black here, and before the procedure most were really bad, or at least class 3, and then they got significantly better after the procedure. And we also found that there was a very low complication rate during follow-up in these patients. So we think that this may be even a safer way of doing it. But the big problem with aortic valvuloplasty is that, unfortunately, although you can get an increase in the size of the valve initially, 6 months later it gets smaller again. And this term, or what's called restenosis, re-narrowing of the valve, has been reported to occur in 50% of patients at 6 months. And there's been never any real clear benefit on survival shown with this. So although it may offer some temporary or transient benefit, it doesn't have a long-lasting effect. And so for that reason, aortic valvuloplasty is really just reserved for people who are so ill that there's no other option, and we're just trying to get them a little better opening so that they can recover from whatever their illness is, or maybe get them through a surgery and that kind of thing. And so because of that problem or limitation with the valvuloplasty, we really don't have any good options in these elderly, generally higher risk patients, because medical therapy doesn't work, the balloon valvuloplasty doesn't work, open heart surgery is quite risky. And so because of that, people have gotten very interested in a less invasive way of replacing the valve called transcatheter aortic valve replacement. And there are two main ways of doing this. One, again, is by going through the groin and advancing a catheter with a balloon and what's called a stent on it. And this stent is basically a new valve, and I'll show you an animation of this. In that way, we can replace the old valve. Or if the vessels in the legs are too small to accommodate the device, we can make a small incision in the chest wall and go through the tip of the heart. And that's fairly invasive, but it's still better than doing a complete incision in the sternum, and also better than the patient isn't on the heart-lung bypass machine. And avoiding both of those things helps decrease the morbidity and mortality of the procedure. So if we go to the next slide, hopefully this animation will play. If you go ahead and press that. So this is a cartoon showing, again, here's the heart, and you're going to see a cross-section, and this is a depiction of a very narrowed calcified valve. Those leaflets should be opening wide open, but they're not. And the way this procedure is done is that we first advance a wire up through the groin, up the femoral artery into the aorta, and we advance this wire across that very narrowed valve into the left ventricle. And then over that wire, we're able to run a catheter or tube that has a balloon near its tip. And we perform essentially a valvuloplasty. We do this in order to open up the valve so there's enough space for us to put in the percutaneous aortic valve replacement. So once we've opened that up, then we advance a real big tube that's almost 8 millimeters in diameter. And through that, we're able to advance another catheter that has, again, a balloon on its tip. But around that balloon is a metal tube or stent that has new leaflets sewn into it. And you see we position that within the old valve. And then again, we inflate that balloon, and that metal tube gets expanded, and it squishes up the old valve. And then what's left behind are the new leaflets inside that metal stent, and they basically function like a brand new aortic valve, and they allow blood to leave the heart normally, and they prevent it from coming back, and the old valve is just squished up against the aorta, just like that. And if we could go to the next slide. So the transcatheter aortic valve replacement, it was first proposed in the early 90s, and there was a lot of experimentation in animals. The first human implantation occurred in France in 2002. And now over 10,000 have been performed worldwide. It's approved in Europe, and so they've been doing it quite frequently. In the United States, it's still under experimental evaluation, and I'll talk about that more. Initially, it was performed by going through a vein in the leg and then going across from the right side of the heart to the left side, and it was a much more complicated technique. But as the device got smaller, in 2005, it became possible to do it the way we saw that animation, by going up through the artery and backwards or retrograde into the left ventricle. And then in 2006, that technique where you can go through the apex of the heart was first performed. And it's generally done in what's called the cath lab, the cardiac catheterization laboratory. And this is the area where we do our angiograms when we're taking pictures of the coronary arteries, and where we put in the stents in the coronary arteries. It can be done there, or also sort of a hybrid room that's a cath lab and an operative suite. And we usually do it under general anesthesia, although some places are doing it even under local anesthesia. But in most cases, we've been doing it with a patient on a breathing machine and unconscious. You need to have very good imaging, because it's critical, obviously, to position this new valve in the correct spot. And in most cases, we've been, with the help of our surgeons, doing a cut down onto the artery in the groin in order to be able to adequately access that artery. But we have done a case where we've done it entirely through the skin, and that without any surgical incision, and that's something that's being done more and more commonly as the device has gotten smaller. These are pictures of the two valves that are being used in Europe, and the one on the left is the one that we are now studying in the United States, and soon we should be studying the one on the right in the next few months. And this valve on the left is a stainless steel balloon expandable stent, meaning you inflate a balloon like you saw in the cartoon. It has cow or bovine pericardial leaflets. So the sac around the heart of a cow is used to create the new leaflets. And it's the same tissue that's used in the traditional valves that are placed surgically. And so we think that it's durable. And it's available in a couple sizes. And there's just some other issues there about its height and things that aren't too critical for this talk. Now, there have been some early experience reported in the literature in Vancouver in Canada. There's a physician, Dr. Webb, who has a great deal of experience, and he reported his first 50 cases a couple years ago now. And these were elderly people, many of them were women, who had prior surgery and severe lung disease. Many of them had already had open heart surgery before. They also had poor heart function. The heart was weak, and some of the other valves were leaky. And so their predicted 30-day mortality was more than 10%. This was a very high-risk population. And they found that the valve functioned quite well. The blue line shows the increase in the valve area, and the red line shows the decrease in the gradient over the first year. And it seemed to be very durable, although we don't have a lot of long-term outcomes still. And what they found was that the survival wasn't, it was good, but it was still, there was a significant mortality because, again, these are high-risk patients. But it got better as the operators got more experience. So the second 25 patients did better than the first. And they've now reported their 30-day survival in 164 patients, so many more patients. And on average, it was about 8% with this technique, whereas it was predicted to be almost 10%. And again, the second half of the group did better than the first half. Now, the other valve that's available is what's called the core valve, and it's a self-expanding valve that is made of not stainless steel, but something called nitinol, which is a metal that once it's released will form a certain shape and stay in that shape, and this is the shape that it stays in. It has pig pericardial leaflets, which is similar to the other one, but not cow. It's a little bit smaller, so it's a little easier to deliver, and that's just, again, some technical terms that aren't necessary. This shows the valve being deployed. It's right here. And as the catheter is pulled back, you see it expand. It just pops into its own size and then, again, squishes up the old valve. Let's go to the next one. And the experience with this valve is significant in Europe. It's been used quite commonly. And you see that initially the chance of dying at 30 days was high in the 15% range. But as experience increased, it's now down to 6.7%. And all of the other complications, heart attack, having a funny heart rhythm, stroke, have all decreased significantly with experience. And this is just a graphic to show you how this technology has really taken off. These are data, again, from Europe. And there have been, with this valve, over 5,000 implants. The other valve, the Edwards one, has also been used over 5,000 times at a number of centers in a number of countries. And you just see how it's really exponential. So there's a great enthusiasm about this technique. Now, I'd just like to spend a few minutes talking about what we're doing at Stanford. We're part of a multi-center study that's being coordinated out of Columbia, and it's called the PARTNER study. And it's the pivotal trial that's being performed to evaluate the safety and effectiveness of this Edwards valve to see if the FDA will approve it or not. And the way it works is that we are including patients who are high risk. And the way this is determined is by using a calculator that's on the web that is put out by the Society of Thoracic Surgery. And you plug in a patient's age, their height and weight, their gender, what other risk factors they have they had heart attacks or coronary disease, have they had prior surgery, how's the heart functioning, how are the kidneys, the lungs, and then the calculator spits out a prediction about what the mortality would be with traditional open heart surgery. And if the prediction is more than 10%, then the patient's definitely considered high risk and qualifies for the study. Then the next step is determining if the patient is a candidate for the traditional surgery, or are they so high risk that the surgeon and cardiologist feel there's no way we would ever recommend surgery. If they're still felt to be a candidate, they fall into cohort A. And let's go to the next one, and you'll see that the first thing we do is evaluate the access in the groin to see if it's good enough. And if it's big enough, then the patient is randomized to either what's called transfemoral, where we do the replacement through the groin, or to open heart surgery. And in the study, we had no control over that randomization. Half the patients would get surgery the traditional way, and half would get it through the groin, and a computer decided. And it was set up that way so that we would have two equal groups and that we could compare them and find out in the end whether or not one was better than the other, one technique. If the patient's femoral access is not good enough, then they go to the next slide and they get randomized to either, again, the traditional surgery or an approach through the tip of the heart, that transapical approach. Now, if the patients are too sick to be a candidate for surgery, they fall into cohort B. And again, they have their access evaluated, and if their access isn't good enough, they can't be in the study. But if their vessels are big enough, then they get randomized to either the valve replacement through the groin or to medical therapy, which we know isn't very good. Often it would include a valvuloplasty. But again, because this is a new device and we don't know about its safety, the FDA, when this study was first designed, the FDA mandated that we do it this way. Now, the good news is that the study has completed enrollment. We finished about 3 or 4 weeks ago. We included about 40 patients at Stanford, and again, there were 20 some odd other sites around the country who were enrolling patients too. And now we have a registry that's available to us, so patients don't have to get randomized. They still have to meet all the criteria to be included, but then they either get a valve through the groin or through the apex, and they don't have to be randomized. So that's quite nice now. And we don't, the main endpoint, if you go to the next slide, is the and one more, is the 1-year mortality between the different groups. And we won't have those data again until next year around this time. So what I'd like to do is show you how we do this in the cath lab, and also show a case example of a patient. This is basically us advancing the catheters through the groin site there, and that's the X-ray machine. And you'll see that this is quite an effort. There are 4 attending physicians, 2 cardiac surgeons and 2 interventional cardiologists who do the procedure. And we also have anesthesiologists helping us. We have an echocardiographer, a cardiologist who specializes in echo. We have a number of circulating nurses helping us. So it's really quite an endeavor to pull this off. And I'd like to show a case that will hopefully exemplify how, what kind of patients involved. This was a 75-year-old woman who had critical aortic stenosis, very tight narrowing of her valve. She had long-standing lung disease. She had been a heavy smoker, and so she had emphysema, or COPD, and the amount of air she could blow out in 1 second was very low, and that's an indication of how severe her disease is. She also had some kidney issues as well, which increased her risk, and she had many years of this valve narrowing without any symptoms, but then about 9 months ago developed heart failure symptoms with trouble breathing, waking up at night short of breath, swelling in the legs, some chest heaviness. And so I saw her in the clinic, and you could just press through these. Basically, this just goes through her physical exam. She had signs of heart failure, is the bottom line. And then her ultrasound or echo of her heart also showed that she had a very, very tight aortic valve and poor function of her heart. And so her predicted mortality was almost 10%. They give us a little bit of wiggle room in enrolling patients. And our surgeons thought that she was too high risk for open heart surgery. So she was included in that cohort B. Fortunately, she was randomized to the transcatheter aortic valve replacement. And we went ahead and then brought her to the cath lab. And if you go to the next one, first we took pictures of her arteries in her heart to make sure they were okay and not contributing to her issues. And we also do a very thorough investigation of the vessels in the leg, again, because this is a large tube that we're putting in there, and we don't want any surprises, and we want to make sure that we can do it safely. And this just shows that's a picture of her, two different pictures of the arteries in her legs leading up to her aorta. So then to orient you, this is a picture of the chest wall with an X-ray, and this is the spine in the background here. And that thing up there is a echo probe that is actually down the patient's esophagus, and it allows us to see the heart during the procedure. The patient is on a breathing machine, and then we have a wire here in the ventricle, the pumping chamber in the heart, and we're passing a balloon across that to do our valvuloplasty. And then this is a wire in another part of the heart that's going to pace the heart very rapidly so that it doesn't beat well. And if you press the button again, this essentially shows us getting ready to deploy the valve. This is that stent, and it's on a balloon, and we're doing an injection of contrast in order to line it up so that it's in the right place. And then I think if you go to the next one, this shows us pacing and then inflating the balloon, and that's the stent getting expanded, and then the balloon deflates, and inside that are the new leaflets that immediately start functioning. And you just go like that, and then we remove everything and basically sew up the incision in the groin, and the patient returns to the ICU, is taken off the breathing machine. And in this case, she recovered quite quickly. She was in the hospital for 4 or 5 days and then went home. This is an echo picture, and this is the main pumping chamber at the time when we first met her. And I think you may be able to appreciate that it's not squeezing in very well, and that's because it's under so much stress due to that narrowed aortic valve. But once we got the new valve in, we just saw her a few weeks ago at her 6-month follow-up, and now you see how much happier the heart is and how it's squeezing so much better, and the valve is opening much more effectively. So I'm almost done, and I'll be happy to take questions. There are a number of limitations. We can go through these pretty quickly. It's a big device, high profile. There can be leaks around the valve, which usually aren't clinically a problem. Rarely, the valve itself can block one of the coronary arteries, which obviously isn't a good thing. But we'll talk about strategies to avoid that. Stroke is still an issue in a few % of patients. And some patients require a permanent pacemaker afterwards because the new valve disrupts the electrical system of the heart. And we're unable currently to reposition or move the valve. So once we deploy it, that's sort of it. And that's why we pay so much attention and have so many people involved to make sure that we're doing this accurately. And then the big question is, how durable are these valves going to be? The gold standard technique of open heart surgery has been tried and true, tested for 20+ years, and these valves are quite durable and are getting even better and better. And so that's going to be a big question that we'll only know with time. It is interesting to see, though, that despite these limitations, this technology is really taking off, and the prognosticators out there really think this is going to have a big impact, and I think they're right. This shows the predictions regarding the market value of what's TAVR stands for transcatheter aortic valve replacement, or what we're talking about. And you can see, compared to traditional either mechanical or tissue valve replacement or repair, the prediction is that by 2012 it's going to dominate the market. And then this next slide shows a similar sort of prediction. If you go one more on this, you'll see that currently, or in 2007, very few patients had this transcatheter valve replacement, less than 0.2%. The prediction is that by 2012, this will be 40% or more of patients undergoing it in this manner. This one you can also press through. As you can also imagine, here in Silicon Valley, there's a huge explosion of companies looking at newer and better ways of doing this. And so these are just some pictures of the different technologies that are being tested and proposed that may be able to address some of the limitations of the current two valves that are available. Things like being able to reposition the valve. Some of these devices, you can partially open them, and then if you don't like it, collapse it and move it and then reopen it. Some of them are less likely to block the coronary arteries, and hopefully less likely to cause stroke as well. So a couple of concluding remarks. I would be remiss if I didn't state that traditional surgical aortic valve replacement is still the gold standard. and the accepted way of treating symptomatic aortic stenosis. But what we're learning is that this transcatheter aortic valve replacement is feasible, it's reasonably safe, and it holds great promise for the treatment of aortic stenosis. If you have questions regarding the partner trial at Stanford, you can go to the website that's listed there, and if you search aortic valve, then a whole thing will pop up about the study and the inclusion and exclusion criteria and all different things. Our nurse coordinator for this study, her name is Martina Spate, and her phone number is listed there if you have questions as well. With that, I'll stop, and thank you for your attention. Yes, it is. That was a great coup for the company planning the study, but yeah, Medicare covers the procedure. Yes. So the question was regarding treatment, medical treatment after the valve replacement, and whether patients require Coumadin or blood thinners like that. Fortunately, patients do not require Coumadin, but they do require at least aspirin, and it's recommended that the combination of aspirin and clopidogrel, or Plavix, you've probably seen commercials for it, is used. In general, in some of these patients who are elderly, the risk of bleeding can get to be a problem, and so we may just use one of those, but the recommendation is 2 of them for 6 months. Yeah, the question is about the timing of aortic valve replacement and whether it's appropriate in a patient who doesn't yet have symptoms. And the indications currently are for patients who have clear symptoms. There is some controversy about asymptomatic patients who have very severe aortic stenosis, because there is a small chance that a patient will essentially drop dead with severe aortic stenosis without any warning. And it's very small, but that risk is there. And so the question is, when does that risk outweigh the risk of having the aortic valve replaced surgically? And that's always a difficult one that both physicians and patients struggle with. We do have some data in the literature to identify patients who are at higher risk for something like that happening, or who are at higher risk for rapid progression, which would require replacement. So in some cases, it is suggested or recommended that a patient has the valve replaced without symptoms, but again, the guidelines state that severe aortic stenosis with symptoms is the main reason for doing it. So I don't know if that answers it. Yeah. So the question is this technique in the United States still being done as a study, or is it now available for use as we feel appropriate? And the answer to that is it's not yet available. So the FDA has not approved it. So the only way that it can be done is at one of the sites that is participating in this study, and only in patients that meet the criteria for enrollment in the study. But the main difference is that since the enrollment has concluded, the FDA has granted continued access to the device under these very strict regulations, but not in a randomized fashion any longer. So prior, the patient would be randomized to, open heart surgery or the valve. Now, they're guaranteed of getting the transcatheter valve, but it's still very closely monitored, and we actually have a limited number that for the next 6 months, and then hopefully the FDA will, increase that again. And there's some other studies that are being planned that will be opening up soon too. So.
And the limited number is not filled.
No, not yet filled. It's still available. And the other thing is, in Europe, it is approved by their, equivalent of FDA, and so there they can do it as they please. Yeah. Yeah. So the durability, I didn't show the data, but at a recent meeting, a colleague presented 2-year durability data, suggesting or not having any red flags, so that it looks like it's durable. Since it's the same tissue that's used in a traditional valve, we suspect that the tissue should be equally durable. It has been tested in bench models where, they do like 1 million or 10 million, beats, and it has held up. So we think that it's going to be durable, but again, only time will tell. So we have encouraging data, nothing yet to suggest that it's not durable. As far as which valve is better, The core valve, or who bought now by Medtronic company, is in the planning phases of their pivotal study, and that should start in the next 6 months or so. There are some advantages to that valve. In its current form, it's a little bit smaller. So in some patients where the Edwards valve might not fit, the core valve might. Having said that, the Edwards has come out with a smaller valve that's equally sized to the core valve, and that's going to be tested in the near future too. So I'm not sure we know if one is better than the other. I think there are pros and cons to each one, and again, time will tell as we get more data.
You're interested in trying the second one as well?
Yeah, we hope to be involved in that study too. No, the blood pressure is generally affected by our genetics as well as our kidney, what we eat, and our kidneys. And so the valve itself doesn't usually, it'll impact the pressure in the left ventricle. So when the valve gets narrowed, that pressure will go up, but the pressure that is in the systemic pressure is not affected by the valve. Yeah. Yeah, is there any issue with the valve migrating? And the main issue is at the time of deployment, the valve, if it's too small, it won't have something to grip onto, and it can migrate or embolize. There have been anecdotal, like maybe 1 or 2 reports of later migration of the valve, again likely due to inadequate sizing. But if the valve is adequately sized, we don't have any evidence to suggest that it moves. So the question is, will this procedure ever be the gold standard? My guess is that some form of this may be. I don't know if it'll be this exact method. I think there's a lot of ideas and concepts being floated around that may be even better. But yes, I would envision that opening up someone's chest with a traditional sternotomy will not be the gold standard for much longer. I mean, maybe it will for the next 5 or 10 years, but after that, probably not. Yeah, so that's the exact dilemma that we have. Patients who have already had surgery, they've been through it once, they have bypasses that are working, and you aren't too anxious to go back in there and potentially screw up those bypasses in order to replace the valve. And having to go through a repeat operation, of course, is riskier and that sort of thing. So in this situation, we do definitely wait until the patient has clear symptoms and is not happy with their lifestyle and is limited significantly by the narrowing. And in that case, this technique would be a consideration for sure. The average age of the patients that we enrolled in our study was 88.5 years old. And yeah, and we did it in patients as old as 96. So we have experience in elderly patients. But yeah, it's a difficult decision. It takes a lot of thoughtful care, and I think there's a lot that goes into the decision. So, but certainly this is an available strategy that could be considered if it's necessary. Yes. Right, so the question is, what's the most common complication, and do we find it more difficult in women because of the size of the vessels? I think the most common complication, I guess it would be probably the need for blood transfusion, because during the procedure we've been doing these surgical incisions and there can be some bleeding and oozing, and so that's probably the most common thing that happens that could be considered a complication. Patients rarely have heart attacks associated with the procedure, rarely strokes. These have been like 1 or 2 out of the 40 or so patients. So it's fortunately, our experience, we've been very pleased with the complication rate. As far as women, yes, the size of the vessels are smaller, and so that is a limitation in some cases, and we're not able to do it through the route from the groin. And in that case, we can consider going through a mini thoracotomy, a mini incision in the chest wall and going through the apex of the heart. Yeah, so that's a great question. Can this be done in patients who've already had an aortic valve replacement? If it's been with a tissue valve, what we call a bioprosthesis, yes, it can, and that is in fact one population or subset where it's expected to have a really early impact because it can be done there and it has been done there effectively. If the patient has a mechanical valve, which is a valve that requires Coumadin, and it's not made out of tissue but out of sort of plastic essentially, or metal, those patients, it can't be done in them. Well, so the question is, what do we tell our patients who have severe aortic stenosis and have symptoms but are actually not unhappy with their symptoms and they're okay with their lifestyle and don't feel compromised, although they have significant symptoms? And I think we just have to be honest and tell them, look, this is the usual progression of the disease. We don't have a crystal ball. We never know for sure. You could do fine for a number of years, but these are the chances that that would or wouldn't happen. These are the risks of the procedure, and these are the chances, of a good or bad outcome. And, inform the patient as best we can, and then ultimately the decision is up to the patient and their family, and we never try to force people to do one thing or the other. We just want to make sure they have all the information, and usually that'll also involve a discussion with the patient's primary care physician as well as their cardiologist who's referred the patient, just so that everyone's on the same page, and then whatever the patient decides obviously goes. It's always better to wait for the second or third model, right? You don't buy the first iPhone, you wait for the 3G to come out. So, yeah, I mean, these are predictions based on, these consulting firms calling up or emailing, thousands of cardiologists and cardiac surgeons and asking them, what do you foresee? And then looking at, the economics of it all and then putting it into, some kind of predictive model and coming up with it. So who knows if it's going to bear out or not. But yeah, if you don't need something right away, then certainly it's probably better to wait and let people gain experience and wait for that next model. So the question is, what's the major advantage of this procedure? The main advantage is that it avoids the need for sternotomy or incision in the chest wall, and it also avoids the need for the heart-lung bypass machine, where you basically freeze the heart and you circulate the blood through a machine in order to keep the patient alive while you're doing the procedure. And both of those increase the risk of the procedure and the chance of having an adverse outcome. And so by this technique, you're able to avoid that and decrease the risk. Yeah. So the question is, are any studies being done on younger patients who are lower risk? And those are in the planning stages, probably a year off or so. Again, as investigators and physicians, we want to make sure that it's safe and feasible in the group that's already been studied before launching a study in lower risk patients. So once we feel more secure about that, and once the FDA does, then I think they'd be more likely to approve a second study. But that is being planned. Now, it'll probably be, small increments, going to patients with, say, a 6 to 10% chance of dying. The average risk of open heart surgery to replace the aortic valve is around 3% or 3 or 4% chance of dying. So it'd still be higher risk group, but not as high as what has just been studied. So the question is whether a mechanical valve lasts indefinitely. The data suggests that the mechanical valves last longer than the bioprosthetic valves, but both have a risk of failing, and neither is perfect. But certainly a mechanical valve, the chance of it lasting longer is better than the bioprosthetic valve. But of course, the trade-off is that you have to take blood-thinning medicine, Coumadin, long-term with the mechanical valve, whereas you don't have to do that with the bioprosthetic. Question is Coumadin causing heart attacks? No, no, it's not. I think you have to review your literature sources.
Okay. I just read everything.
Yeah. Okay, thank you, everyone. Yeah.
For more, please visit us at stanford.edu.